Welcome, Dr. Prajakta. Today there is change. One coordinator is absent. Dr. Vedehi is not able to join. So Dr. Prajakta will be coordinating with me.
Good evening, sirs. Can we start?
Yes.
Good evening, respected faculties and delegates present over here. On behalf of Corona Remedies Limited, I, Shubhankar Dharmadhikari, welcome all of you for the Core Connect Live webinar in association with AMOGS SMC and Indian Menopause Society for celebrating the World Menopause Day. I will take this opportunity to introduce our coordinators for today's webinar. Let me share my screen. Sir, is my screen visible?
Yes.
So our convener for today's webinar is Dr. Madan Kamble sir, who is a chairperson of AMOGS SMC. Sir is also a member of Foxy Sexual Health STI committee. And our coordinator for today's webinar is Dr. Just a second, sir.
यही है डॉक्टर प्राजक्ता ही है.
Dr. Prajakta Gude ma'am, who is an MBBS DGO DNB FICOG Fellowship in Reproductive Medicine. She is the director at the Maher Maternity Hospital and Nucleus Test Tube Baby Center at Udgir. I welcome you all for this webinar, and I hand over the session, the webinar to Dr. Prajakta Gude ma'am. Welcome you.
Yeah, thank you. So I like to welcome all the guests of honor and guests for today's program. Thank you, Madan sir, for giving me an opportunity to have a coordinator with you. So today we are having the webinar on World Menopause Day. That is, the theme is lifestyle medicine. So we'll start with the program with the lamp lightning. So we'll start with the webinar for today. I'd like to hand over Dr. Madan sir for introducing our guest of honor for today's program.
Yes. Thank you, Dr. Prajakta. I welcome all for this specially organized webinar by AMOGS Sexual Medicine Committee in association with Indian Menopause Society. This is specially organized because this month is World Menopause Month, and we are having World Menopause Day. The world is celebrating. It is on 18th of October, the theme of which is lifestyle medicine. As the Indian Menopause Society is a very active society, and we are very happy to associate with IMS with permission and blessings of the President, Dr. Anita Shah ma'am, Secretary Dr. Ragini Agarwal ma'am, and past President Anju Soni ma'am, and our own AMOGS office bearers, respected Dr. Kiran Kurtkoti sir and Dr. Bipin Pandit sir. I'm thankful to both of these organizations. As our today's chief guest is Dr. Suchitra Pandit ma'am. I think ma'am is not joined yet. I would welcome our today's guest of honors, Dr. Kiran Kurtkoti sir. Shubhankar, please display the slides. He is the dynamic president of AMOGS
It's okay. Thank you, Madan. Thank
Yeah.
you. Thank you. Will
Yeah.
not
Welcome,
complete
sir.
it.
Welcome, sir.
It's been today's program and the function. So thank you at the outset, respected Chief Guest, Dr. Suchitra Pandit, our guests of honor, my co-guests of honor, Dr. Anita Shah and Dr. Anju Soni, and of course, IMS office bearers, Dr. Ragini Agarwal, a close friend of mine. So thank you, Madan. I mean, it's really a good thing that you have got two great organizations together, AMOGS and of course the National Indian Menopause Society. So thank you for that. And on the occasion of World Menopause Day, we really look forward uh, to the different aspects that touch upon menopause, namely the genital urinary syndrome, the sexual health in midlife, and the recent update in MHT. So warm wishes to you, and I see a lot of people who are going to enter into the election phrase. So my best wishes to you, to Dr. Prerna also, and of course our own Dr. Prajakta at some point of the time or the other. And with this, I would request Madan, please get on with the program. And I would like to invite all the viewers to two conferences, rather three conferences. The first one that we are going to hold in Sholapur, that is on 1st and 2nd of November. Then we have the Star Sampurna Presidential Conference in Pune, organized under the aegis of Foxy by Dr. Sunita Tandwalkar on 14th, 15th of November. And lastly, Madan is going to have a big bash and a very great conference in the city of Kolhapur. We all welcome you on 12th and 13th of December in Kolhapur. In association with Kolhapur Society, Madan is doing a conference on sexual medicine or sexual health. So these are the three conferences that AMOGS is lined up for you. A warm welcome on behalf of myself to everyone, and best wishes to you, Madan. Really, you are doing a fantastic program, and I really, there are some decisions that a president makes, and I would like to tell you on record that this is one of the best decisions that I have made. That to appoint you as the chairperson of the Sexual Medicine Committee, and you have done full justice to this committee. Thank you for the same. And my best wishes to today's program as well as the programs in the future. Thank you.
Thank you so much, sir. You're always like a great support behind us. Thank you so much for that kind words. Shubhankar, next, I would like to invite, I welcome Dr. Anita Shah, ma'am, who is the president of Indian Menopause Society, also past president of Surat OBGY Society. She has been organizing chairperson and secretary of many conferences. I welcome, ma'am, and we need your blessing, ma'am. Over to you, ma'am.
Yeah, a very good evening to all of you, and thanks a lot, Dr. Madan, for inviting me over here to this very unique webinar. As you all know that 18th October we are celebrating as World Menopause Day, and the whole October month we are celebrating as Menopause Month. The urogenital problems and sexual problems are two very important aspects for the menopausal and postmenopausal women. And of course, so many times women are the sufferers silently, and the education awareness regarding all these topics are very, very important, because we always believe that sex is a natural instinct like hunger and thirst. We have to just find out the problems and advise the solution to our midlife women so that they can remain healthy and happy till the later age of their life. So without wasting much time, my all the best wishes to dear Dr. Madan for this wonderful webinar and for your future endeavors. Okay. And thanks a lot to all other dignitaries also. Thank you very much.
Thank you so much, ma'am, for your kind words. We have our chief guest, Dr. Suchitra Pandit, ma'am, here. I welcome, ma'am. Ma'am is the past president of Foxy. Everyone knows, ma'am. Actually, there is no need of introduction. Ma'am was chairperson of AICC RCOG, past president of ISOPOP, Justice.
Madan, okay, we'll
yeah,
it's
welcome,
okay, Madan, no problem.
Welcome.
Yeah. First of all, thank you very much, Madan. First, congratulations to you for organizing so many webinars time and again. And this particular thing on the eve of the World Menopause Day, I think it's a very, very important thing when you're talking about the midlife problems that are there, very nicely taken up. And I see the program, you've got very good, speakers on this subject too. So congratulations to you and best of luck for all your future endeavors. And I must say, Kiran Kurtakoti has made a very good choice as president of AMOGS. And I haven't met Bipin as yet. He is the secretary of AMOGS. And of course, Anita Ben, nice to see you on, on the webinar, at least after maybe we met in the AICOG, but lovely to see you. And Madan, I wish you all the best. I think the midlife is a very important phase of life, considering that currently India is the youngest country in the world, because almost 30% of the population is living under the age of 25. But another 20 years down the line, we will be someone, will be the largest amount of women in the middle age group. So very important, the uh, congratulations, and thank you very much. Thank you very much for inviting me. Thank you, Madan.
Thank you so much,
Sorry
ma'am.
to interfere, Madan. Thank you very much, dear Dr. Suchitra. I do remember your visit to Surat so many times, and we are heartily inviting all of you for AICOG 2027 in Surat. So,
Yes.
waiting eagerly to host all of you at our lovely place, Surat.
Yes, 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 absolutely. Thank you
Yes.
so much.
Hello, Dr.
Hi, Pragya. I didn't see Pragya. I saw a little glimpse of Pragati Kalatkar, but I didn't see anyone else. Well, anyway, wishing all of you a wonderful, happy, healthy Diwali and a prosperous New Year to come. Thank you so much.
Thank you. Thank you so much, ma'am. Now I welcome our next guest of honor, our own Dr. Anju Soni, ma'am, the the past president of Indian Menopause Society, past vice president also. She's the past proxy chairperson for HIV/AIDS committee. Madam has done a lot of work.
Thank
Yeah,
you so
welcome,
much.
ma'am.
Thank you.
Yes,
Thank
welcome,
you so
welcome, ma'am.
much. At the offset, I would like to congratulate you and the team AMOGS for working on this very, very important topic. We all know that the more than one third of the part of woman is in this in perimenopause and menopause. So addressing that age is very, very important. It's my pleasure to join on the eve of World Menopause Day 2025, organized by AMOGS in association with my own society, Indian Menopause Society. We all know that this year's theme is lifestyle medicine in at the white paper, which comes at the opportune time that International Menopause Society has reinforced this by introducing its white paper and fact sheet, which highlights the critical role of lifestyle interventions in managing the menopause and, of course, prompting the long-term health problem in the woman. As IMS white papers outlines, the menopause is not merely a hormone transition. It is a window to reset the health trajectories. And through the lifestyle medicine encompassing nutrition, physical activity, stress management, sleep hygiene, and social support, we can address bone health, cardiovascular health, metabolic changes, mental health as in an integrated way. And the fact sheet accompanying provides accessible guidance for implementing these strategies in the diverse setting. And it will be available at our Indian Menopause Society website. And this evening, as we discussed, GSM, sexual health and midline, and updates on hormone therapy, let's keep the IMS white paper message at the center, that prevention, empowerment, and lifestyle optimization are essential as medical interventions. And I hope that by the end of this event, each participant will feel equipped to translate that global framework into the everyday care and to support the woman in midlife, not just as scope, but to thrive. And I would like to thank thank you for inviting me and congratulate you. Give my best wishes to you, and also look forward to valuable insight by all the speakers. You have collected a good lot of speakers, and it was very healthy change to meet Dr. Suchitra, Dr. Kiran, Dr. Anita, and Ragini, and everyone who has been here, Pragya, Prajakta, each and everyone. Thank you very much for inviting me today. Looking
Yes,
forward.
Thank you so much, ma'am, for your kind presence, kind words, and taking your valuable time. Thank you so much. Before starting the scientific session, myself and Dr. Prerna would like to request all the seniors in Foxy to kindly support us in our Foxy endeavor. I'm going for Sexual Health Committee of Foxy, and Prerna is going for YTP. Please support for us. Thank you so much. Over to Dr. Prajakta. Prajakta, there is change in the sequence. We are going to start first the session number 2 by Dr. Ragini ma'am.
Yeah, thank you, Madan sir. So thank you all guest of honors and our esteemed faculties for your blessings. We'll start with our scientific session. We'll start our second topic, sexual health at midlife. For this topic, I would like to call the chairperson, Dr. Arundhati Kanade ma'am. Slide for this. Madam is consultant at Dinanath Mangeshkar Hospital, and her topic of interest is high-risk obstetric and endoscopy in surgery. I welcome ma'am for this program. I'll like to invite another chairperson, Dr. Pragya Mishra ma'am. Ma'am is consultant infertility specialist at New Life Test Tube Baby Center in Patna. She's been past president. She's at President Patna OBGY Society and Secretary General of ISOPAP. And Madam is at present Genetic and Fetal Medicine Committee of Foxy. So I welcome you, ma'am, for this topic of sexual health medicine chairperson. So I like to invite Arundhati Kanade ma'am to invite our speaker for today's session, Dr. Ragini Agrawal ma'am. Ma'am, kindly introduce our speaker for today's topic.
Good evening, everybody. This is an excellent session here. I would like to invite, without spending more time, Ragini madam to talk on sexual health. And we all know her. She is an excellent speaker. I cannot see the slide, but yes, she is the Secretary General of IMS in current times, and she is the founder chair, Aesthetic Health Committee, Joint Secretary IMS 23, patron of Menopause Society Gurgaon, National Convener of Indian Menopause Society Project 70 Plus, founder chapter secretary of Gurgaon, and pioneer of cosmetic gynecology. She has won various awards, and various publications are in her armamentarium, and she is also the editor of various magazines. Madam, over to you for your lecture. Let us hope she gets well soon. She is not feeling very well, but still she has agreed to come here. Thank you, madam.
Thank you so much, Anuriti, for your kind words. Let me share my screen. Very good evening to one and all, and thank you so much, Dr. Madan and Dr. Anita, for giving me this opportunity. And AMOGS is one association which is so close to my heart. Even AMOGS people don't know it, because it has given me a path to take. It's such a good regional association which has really given me a food of thought. Why not in Haryana? Why not in all Hindi Bhasi Pradesh? So thank you, AMOGS, giving me this pathway and making me really do something wonder inside my Hindi Bhashi Pradesh. And IMS, no doubt, is a very, very close to heart. And the sangam of these two great association is a very good thing. And Kiran is a very close friend. So friends, nothing is possible without the blessing of God's and the gratitude to one and all, because of you are here to speak or to be here. The topic given to me is a very important topic, because the moment women become 50 plus, the word sex is deleted from her life as far as most of the society is concerned. Sexual Health Committee of the Foxy is doing a wonderful job. When I was the VP in charge of the Sexual Health Committee, at that time, my first, under the Neeraj Jadhav, who is now the Vice President from the West Zone, has joined, and he has changed the shape of the Sexual Health Committee and make it is a really, really important committee. So here I am going to talk about the sexual health and the intimacy after 50, a menopause perspective. So why is it that we celebrate aging in terms of wisdom, but silence it when it comes to the desire? A midlife woman talking about desire, talking about sex, really cause a furor among the people. How can she talk about this? She is an older woman. But sexual health matters at every age. It is not about only the physical intimacy, it is a connection, it is emotional well being, and it is a self confidence which gives that value of the femininity to that woman. According to American Sexual Health Association, sexual health is defined as the ability to embrace and enjoy our sexuality throughout our lives. Yet, after the age of 50, changes in our bodies and the lifestyle can pose challenges to maintaining a satisfying sex life. So, what we have to think? Normalize the conversation around sex and aging. Brief overview of menopause and its timeline, and importance of the addressing intimacy as part of the holistic health. Please mind this word, holistic health. Yes, sexual health and the intimacy is as important as your physical health and the mental health. Sexuality does not retire at 50, yet society often treats aging, especially in women, as a time of sexual decline or irrelevance. Cultural taboos and stigma around older adult sexuality lead many to suffer in silence, avoid seeking help, or feel ashamed of normal changes. What are the common misconceptions? Women lose interest in sex after menopause. Pain during sex is just part of aging, deal with it. Friends, we have so many treatment today for it. Dr. Kamble is going to talk about the GSM, and the time has gone when the woman is suffer with the GSM related penetration pain disorders. If I bring it up with my doctor, I will be dismissed. Intimacy means only penetrating sex, that is intercourse. These myths silence real struggles and ignore the richness and the evaluation of the sexuality in later life. So what we have to give the messages? Sexual health is a part of overall health. It impacts mental well-being, relationship satisfaction, and quality of life. Menopause is a transition, not an end. I can say it's a beginning of a golden era. It's okay to ask questions, seek solutions, and talk openly with your partner, healthcare providers, or peers. Because many women experience a renewed sense of self-confidence and even better sex with the right support, because now they're free. They don't have so much of other responsibilities and not have a fear of having a baby. So almost none of the physical activities had any effect on the dementia rates, except for one, partner dancing, which lowered the risk by 76%. This was one longitudinal study of the people over age 75, conducted over a period of 21 years. And look, what is the answer? So menopause is a natural multi-phase journey that impacts mind, body, and intimacy. It is not a single moment, but transition across time, typically begun around middle or the late 40s, and understanding this timeline help us appreciate how these stages affect not just health, but the sexual well-being and the intimacy. Sexual well-being is a part of overall well-being. The World Health Organization defines sexual health as a key component of physical, emotional, mental, and the social well-being. And it's not just about the preventing diseases, it is about fulfillment, connection, and the self-expression. So menopause can shift the dynamics of the intimacy because there is changes in the hormone, which leads to the effect desire, arousal, comfort, and the satisfaction. And if ignored, these issues can lead to stress, isolation, relationship strain, and the lower quality of life. Healthcare often overlooks this dimension. Many women feel uncomfortable raising the topics, and many clinicians themselves avoid due to time, training, gaps, or discomfort. Many times I really wonder when I talk to a group who are not exposed to the Indian Menopause Society, how much less they know about the menopause. Intimacy is not just physical, that is the most important thing to understand. Emotional closeness, trust, communication, and affection all contribute to intimacy, and these become even more central after 50. It is about being seen, trusted, and valued, not just sexual activity. Intimacy means health. It is vital for emotional, mental, and the relational well being, affects self esteem, mood, and the quality of life, often disrupted during and after menopause, but treatable and adaptable, deserve attention in the medical care and the personal conversations. So, when we talk about the menopause, we often focus on the hot flashes, bone health, mood swings. Are we ever talk about her sexual intimacy, sexual health? No, that sexual history is even missing from the general OBGYN history also. When the what is obstetrics? Obstetrics is the fruit of a sex only. It's deeply tied to our self-esteem, emotional connection, and the life satisfaction. It's part of the truly holistic approach of the health. So menopause can bring physical changes that affect sex, but the ripple effects go beyond that touch, closeness, confidence, and the communication in all set. Unfortunately, this topic is still a bit of taboo. Women may not bring, doctor may not ask, but by naming it, we open the door to support treatment and renewed connection. Whether partnered or single, intimacy in midlife and beyond deserve as much attention as we are giving to the cholesterol or the calcium of the woman. So there is a hormone decline, we all know. There's a vaginal dryness, thinning, decreased lubrication. GSM, yes, it is there with the age. Changes in desire, arousal, sexual sensation is there. We all know that HSGD increased during this period. And yes, dyspareunia, because of all these things, there is a pain penetration disorder develops in this life. So, estrogen plays a central role in maintaining vaginal, skin, bone, and cardiovascular health. And as estrogen levels drops, vaginal tissue becomes thinner, less elastic, and drier. Blood flow to genital areas may reduce, impacting arousal and the sensation. Progesterone also decline, affecting sleep, mood, and temperature regulation. Testosterone, through lower than in men, contributes to libido, arousal, and the sexual satisfaction, and its decline may reduce desire and energy. Vaginal dryness, I will not talk much because Dr. Kamble is going to discuss GCM and GSM in detail, but we'll know that the loss of vaginal moisture and elasticity is there. There's something wrong. 1 minute, please. So I'm not talking about GSM because it will be discussed again. I am talking about the changes in the libido and arousal. There's a reduced sexual desire, longer time to become aroused, and less genital sensitivity. And there also is a psychological relation and the lifestyle factor also play a role along with the hormones. And thinner vaginal walls and the lack of lubrication will lead to dyspareunia, which can lead to avoidance of intimacy, emotional distress, or anxiety around sex, a self-perpetuating cycle of the pain and fear. So this hormonal decline is a key driver which leads to the vaginal tissue from plump to dry, thin, and more fragile, and testosterone also decline, leading to the low libido, arousal, and orgasm. So this is the, when we think about the emotional landscape of the midlife intimacy, the main question in the woman's mind when she a younger woman, am I still desirable? I feel disconnected. I miss feeling closeness to my partner. So body image concerns, self-esteem, anxiety, or depression. Effects of the life stage like emptiness, caregiving, retirement distress, they all make lots of havoc on the woman mind, which is already having a lots of fog and difficulties in the life. And the relationship dynamics and the communication challenges are there. Hormonal shifts, weight gain, skin and hair changes, and altered sexual response may lead to feeling less attractive or less like myself. Women often internalize age is beauty standard and leading to lower self-confidence. Concerned about not being desirable anymore can impact the sexual motivation and the openness. And we all know estrogen is not only a hormone to play on the vagina, but it also regulates the neurotransmitters like serotonin and the dopamine. A decline can trigger irritability, sadness, or mood swings, increase anxiety or depression. Mental health symptoms may affect sexual desire, energy, and the relationship satisfaction. So this phase of life often includes emptiness syndrome. I never agree with this word. Aging parents and the caregiving responsibility, career changes, retirement, or the financial anxiety. These cumulative stresses can reduce emotional capacity for intimacy and the connection. So long-term partners may experience changes in desire or physical function themselves. Then there may be mismatched expectation around sex and intimacy between the partner, lead to frustration, avoidance or silence, or loss of emotional connection. Many couples simply don't talk about sex, and silence can erode trust or closeness over time. Relationship can suffer if communication about sex and the feelings become strained or non-existent. It is not uncommon for couples to avoid the topic. And these patterns can be interrupted with awareness and the tools, and we can begin to rebuild the connection and the confidence. So intimacy is not what we do, it's how we feel doing it together. Physical touch, mental agility, emotional closeness, and the mutual presence is the key for a older age connections, intimacy, and having a good life. So intimacy versus intercourse have to expand. The role of touch, affection, and the emotional connection should be in the forefront. Mindfulness and the senses focus exercise also help. Sex does not have to mean intercourse. Intimacy is anything that fosters connections and the closeness. Intimacy is not limited to penetrative sex. It is about closeness, connection, trust, and the vulnerability. Often calls for a paradigm shift, moving from the performance-focused sex to pleasure and the present-focused intimacy. This broader definition includes cuddling, kissing, hand-holding, shared laughter, meaningful conversation, non-sexual touch, and the emotional availability. Oxytocin, the bonding hormone, is released through touch and affectionate connection. As estrogen declines, touch becomes even more important for nurturing desire and the emotional safety. Regular affectionate contact without pressure to perform can help the rebuild trust and awaken desire. For many women, emotional connection precedes physical intimacy, not the other way round. Coming to the mindful and the sunset focused exercise, it enhances the body awareness, reduces anxiety, and increases pleasure. It shifts attention to the here, now, and rather than the performance worries. The sunset focus developed by the Master and the Jones, he is the father of everything when we talk about the sexual medicine, is a therapeutic approach that focuses on the non-demand exploratory touch, help couples rebuild physical intimacy without pressure, encourages noticing subtle sensation and the mutual comfort, and these exercises can revive connection and the curiosity, especially when intimacy has become strained or painful. So the goal is to create a safe space where intimacy feels joyful, not stressful, where partners feel connected, seen, and appreciated with or without sex. So what are the treatment and the solution? There are medical options. You can treat your GSM or with the estrogen creams, and sometime if it is really not the GSM but the other hot flashes and all, you can use systemic HRT. Then there are non-hormonal lubricants and the moisturizer. Lifestyle approach is must to maintain a good health in the midlife woman. diet, exercise, stress reduction. Pelvic floor therapy is very, very necessary. It is not only Kegel exercise, it is something beyond that. We call this today pelvic floor muscle therapy, and counseling in form of the sex therapy and the CBT for the sexual dysfunction is an important tool. So when we talk about the hormone therapy, local estrogen therapy is a golden standard. Basically, the cream which does not absorb, not the part of the estradiol cream, which is a part of the systemic MST. Please remember it. Systemic hormone therapy, usually it is not in guidelines to give the improved libido or overall well-being, but testosterone offline can be given for these things and may benefit some women with the persistent low libido. Lubricants, moisturizers, and today we have all these energy-based devices and HiFem chair, which has really a very good option for the vaginal rejuvenation. As far as pelvic floor physical therapy, it addresses the vaginal tightness, pain with penetration, pelvic tension and weakness. And sex therapy or couple counseling is especially helpful where the emotional disconnect, mismatched desire, or communication difficulties are present. When we talk about the communication and the partner involvement, talking about needs, desire, and changes openly, tips for initiating conversation with partner is very, very important, and the value of the joint exploration and the adaptability. So friends, whether you are navigating this solo in a long-term relationship or in a new one, you deserve tools that support pleasure and connection. Menopause isn't the end of intimacy. It's a doorway to a new chapter, one that can be deeper, more empowered, and even more fulfilling. Open, honest conversation about needs, fears, and expectations are crucial. Encourage the use of I feel statement instead of blame. Schedule intimacy time. Humor, curiosity, affection to lower defensiveness. Encourage women to advocate for their sexual health. Self-advocacy include asking for the treatment options, seeking referrals, challenging the belief that sex after menopause does not matter. Your pleasure and the connection matter at every age. Some useful tips. The menopause is not the end of the intimacy. It's a new beginning. It evolves, and so can our understanding of the pleasure and the connection. Every woman's journey is unique and valid. Whether you want more sex, less sex, or no sex, it's okay. But it matters that your needs are heard. Pain is not normal. Silence is not a strength. Ask for help. Explore your options and claim your voice in a healthcare setting and relationships. Intimacy can mean closeness, laughter, presence, sensual touch, and the emotional safety. It's never too late to reconnect with yourself and your partner. Then lots of things are coming in new word, like single women re-entering dating, LGBTQ and perspective, sexual health screening, and the STI protection at any age is necessary. We can't say that we stop doing the HIV after the 60 years. So conclude, sexual health is a lifelong journey. Encourage curiosity, communication, and the self-compassion. Leave with an empowering message. Intimacy doesn't end, it evolves. I want to end by saying this. Menopause does not end your story. It opens a new chapter. And in this chapter, you get to define what intimacy, sensuality, and connection look like for you. Whether that means rediscovering your own body, deepening a relationship, or simply learning to speak up of your needs. You have every right to joy, pleasure, and love. So let's stop whispering about sex after 50. Let's talk about it openly, honestly, and with pride. Thank you so much for your patient hearing.
It was a wonderful talk, Dr. Ragini Agarwal. Truly, it was wonderful. I think I'm audible, Dr. Kamble?
Yes, madam.
Yes,
Yes,
ma'am. Yeah. Actually, I don't know whether you've spoken on it before, but I'm hearing you for the first time on this particular subject, sexuality at menopause. And it was I mean, it was really great, to listen to you, and the slides were wonderful. And it's always a pleasure seeing you and meeting you. And I thank Dr. Madan Kamble for having involved me, AMOGS and IMS office bearers, President Dr. Anita Shah, and you yourself as Secretary, and all the thank you, AMOGS, for inviting me. And I wish Dr. Kamble best of luck in his endeavor. Well, he did mention to me at the managing committee meeting in Mumbai, and I'm sure you're going to come out with flying colors. And also the guests, I think chief guest, Dr. Suchitra Pandit, I think she's already left, and the guests of honor also, Dr. Anita Shah, and past president of IMS, Dr. Anju Soni. And I think I'm missing out on someone, Dr. Kiran, president of AMOGS.
Thank you so much, ma'am.
Yeah.
Thank you so much for your kind words and blessings. Thank you for coming in our program. Thank you so much.
Thank you.
So I really liked actually Dr. Ragini Agarwal's paper. I mean, her presentation, I really liked, I don't praise so much, unless and until I really like something. And I think the next speaker also, Dr. Prerna, she's equally good. And
Thank you so much, Dr. Pragya, for your kind words. And I'm so sorry I have to leave.
Ma'am, your talk was so sweet, so comprehensive. It was covering all the aspects of sexuality at menopause, and everything you have covered in a simple way.
I could just say, like, women's unspoken problems. It comes under unspoken problems.
Yes, I would also like to second. It was an excellent talk, and understanding the sexuality at menopause ourselves and helping our patients get over it is very important for us. And Madam's talk really guided us the best.
Thank you so much.
Yes, Ragini, it was wonderful talk as usual. Ragini is always at the top. And as a leader of Indian Menopause Society, we have extended our slogan of fit at 40, strong at 60, independent at 80 to fit at 40, fancy at 50, strong at 60, sexy at 70, independent at 80, naughty at 90, and healthy at 100. We want each and every woman should be like that. And that is the main goal of Indian Menopause Society, to reach to the grassroots level and cover more and more midlife women so that they can remain healthy and happy in the later age of their life. Thank you.
Thank you so much. Thank you so much.
To hear you, Dr.
I'm so sorry.
What at 100? What at 100?
Healthy at 100.
Acha, healthy at 100. Okay.
Yes, Dr. Ragini, it was really so interesting. I've heard this topic so many times in sexual health, but this was so, a complex, a very compact talk which you have given, ma'am. A compact bundle of sexual health at menopause. Really enjoyed it. And
thank you. Thank you.
Thank you,
Prerna, I'm so sorry I'm not there to listen you and Madan, but I have to leave.
It's okay, ma'am. It's okay. Thank you for coming.
Bye-bye. Bye.
Thank you, ma'am. Now we will invite our next speaker. Next topic, genitourinary syndrome of menopause. For this topic, the chairpersons are Dr. Pragati, ma'am. Dr. Pragati Khalatkar, ma'am. She's president of Indian Menopause Society, Nagpur.
That's all. That's it.
Yeah. And another chairperson for this topic is Dr. Mahesh Joshi, sir. Sir is practicing in Thane. At present, he is president of Thane OBGYN Society. So we welcome you, sir, for this topic, for this chairperson. I would like to ask Dr. Pragati, ma'am, to invite our speaker, introduce our speaker, Dr. Madan Kamble, sir.
Yeah, definitely. So really, क्या मैं introduce करूँ Dr. Madan Kamble को, the person who has organized this wonderful union of AMOGS Sexual Committee and Indian Menopause Society at the eve of Menopause Day. So Dr. Madan, you are doing wonderful work, and all our wishes are with you, and we are waiting to congratulate you as you become the chairperson, really. So he's a consultant, OBGYN and sexual health expert. He works for aesthetic gynecology as well, and he's chairperson of AMOGS Sexual Medicine Committee. and more so he is the national coordinator for FOXY, Sexual Health Committee, as well as STI Committee. He was past secretary and president of Akluj OBGYN Society. And
It's okay, ma'am. Thank you. Thank you so much.
very important that we all should support him and the work he is doing to connect people and to bring out the sexual health of giving a full justice. Definitely. We want to hear from you, genital urinary syndrome. Over to Dr. Madan.
Thank you so much, ma'am. Thank you. Is it visible?
Yes.
Yes, sir.
Yes, sir.
Full screen, na?
Yeah, yeah.
Yes.
Yeah. Okay. Yeah. On the eve of this menopause month and menopause World Menopause Day, yeah, we all are talking about everything about the menopause. There are so many issues, problems, and how to tackle with this. This is the most common symptom, most common problem, the genitourinary syndrome. It covers so many entities that we are going to discuss in short, and how to tackle with this. It is the history of menopause, which unfortunately in the initial era, this was defined as women as a deformed males who after the menopause finally became more like the male ideal. And in 1710, menopause defined as a disease, and it was considered as worst of calamities to beset the female sex. And the initial treatments, which were considered in the early 18th, were to put the leeches on the genitalia and the cervix to manage the symptoms, then application of cold water to the abdomen, use of arsenic, or they used to have to keep sitting in hot rooms and to have sweating more. And so many treatments were there in 18th century. Then let us understand what is genitourinary syndrome. What is the prevalence of this this problem? Prevalence is before the menopause, it is at least 4% incidence is there, and in the menopausal group, 47% incidence is there. In the breast cancer survivors, it is quite high. In premenopausal group, it is up to 23%. In postmenopausal group, it is up to 61%. Then what is meant by actually genitourinary syndrome? It is a chronic progressive condition of the vulvovaginal and lower urinary tract, which is characterized by a broad spectrum of signs and symptoms that we are going to study. This name was coined in 2014 by the International Society for the Study of Women's Sexual Health and the North American Menopause Society. Then what are the symptoms? There are so many symptoms, but most common symptoms are there are cycle changes are there. Common symptoms like hot flushes, tiredness is there, lack of sleep or poor sleep, loss of libido, anxiety is there, stress factor is there, memory loss is there, and physical symptoms like a feeling of dryness in the vagina and subsequently the discomfort in sexual intercourse. And then what happens actually, which pathological changes occur? The vagina before menopause and the vagina after menopause. The vaginal lining, which was initially thick and moist, it becomes thin, dry, and the vaginal walls become, the flexibility reduces, becomes thin, blood flow is reduced in the postmenopausal period. And the symptoms or the effects of vaginal dryness may cause itching in the vaginal area, burning sensation, increased frequency of urination is there. There is always discomfort or sometimes painful sex is there, light color bleeding may be there, and irritation is always there. And as far as the sexual problems are concerned, there is loss of enjoyment in the sex and loss of intimacy is also there. The sad part of the GSM is the 50% of postmenopausal women are affected by GSM, but the percentage of reporting women is very, very less than 25% women report, because they feel embarrassed and they think that this is due to the aging only. And they don't know about the menopause, or very less knowledge about the menopause. Only 4% of women were able to attribute the vulvovaginal symptoms to menopause. Then what effects will the menopause have on sex life? There are many effects. These are due to the lower hormone levels. We can make the vaginal tissue drier and thinner, and that can cause the sex uncomfortable or painful due to the vaginal atrophy. And as the hormones are lowered, may cause the lower sexual drive, and arousal is less, desire is less due to these lower hormones. There may be night sweats which can disturb the sleep. Lady may feel tired. There are so many emotional changes which makes the woman stressed or irritable or with anxiety. And also the physical changes like body disfigurement is always there. What can I do to improve my sexual health before and after menopause? The main pillars are there to manage these menopausal problems: love, care, and tender. One should be very active. Physical activity always boosts the energy level. It increases the mood. It increases the body image, and ultimately, it is going to increase the interest in the sexual life. One can reduce the smoking, because it is definitely going to affect the desire and arousal also. And better to avoid the drugs or limit the alcohol level. And as far as the frequency of sex is concerned, one can have more sex, or when required or when desired. That keeps you fresh and the tissues healthy. Allow some time to become aroused during the sex. Always practice the pelvic floor exercises, because these increases the blood flow to the vagina and strengthen the pelvic muscles also, which are very much important in the orgasm. Avoid the products that irritate the vagina, like strong soaps and bubble bath, which are causing irritation. That should be avoided. Vulvovaginal atrophy and the associated genitourinary symptoms of menopause, such as dryness and dyspareunia, should be addressed well in the women or with hypoactive sexual desire disorders. And the first line therapies should be considered, like vaginal moisturizers and the use of lubricants for the immediate relief from the symptoms. The role of estrogen therapy is very much proved and very important. It improves the lubrication and sexual function in case of vaginal atrophy. It can be safely used in the women in whom HRT is contraindicated, but the long-term therapy is needed. The safety data should also be considered. Then hormone therapy for menopausal female sexual interest arousal disorder. Systemic HRT can improve the sexual function and dyspareunia. Again, the tibolone is also very useful drug, which is having androgenic properties, but it does not stimulate the breast and endometrium. And it may be considered as first choice as HRT in a woman with low libido. Then so many pharmacological agents are coming into the market. Now, plibanserin is also one of the newer drug, which is the only FDA approved drug, which is used for the hypoactive sexual desire in premenopausal and postmenopausal women. Dose is 100 mg once daily at bedtime, but it should be avoided with alcohol or in hepatic impairment cases. Then use of testosterone. It is actually off-label treatment for perimenopausal and postmenopausal women with hypoactive sexual desire disorder. Transdermal testosterone patches are also available. Also, testosterone gel 1% is available. It can be used up to 3 to 6 months, but with caution. At the same time, there are some side effects of testosterone also in the excessive use. Some cosmetic side effects like hirsutism, acne, or sometimes there may be irreversible virilizing changes may be there, insulin resistance, and most androgens are aromatized to estrogens, and that can act on breast and endometrium and cardiovascular system also. It can be used up to 3 to 12 months. And counseling is required in such cases. Buspirone is also one of the drugs which is used for, mainly it is anxiolytic, and it is used off-label as treatment for hypoactive sexual desire. No effects, we can stop after 8 weeks. DHEA, it is available in the market. Very good results are coming with a 100 mg dose, and again L. Hello, my screen is off.
Sir, screen is not visible for you.
Oh, it was disconnected. Okay.
Yeah, disconnected.
Now visible?
Yeah.
Yes.
Yes. Okay. Some PDE5 inhibitors like sildenafil is can be also used. May benefit women mainly in the sexual dysfunctions. This drug increases the blood flow to the female genitals and thereby producing the better arousal sensation and lubrication. There is role of aesthetic gynecology also. There are some non-surgical and surgical procedures for vaginal rejuvenation. Some energy-based devices are also helpful in the treatment of female sexual dysfunctions like radio frequency, lasers, HIFU or HIFM chair. Some minimally invasive procedures are also useful, like platelet-rich plasma, use of fillers, Botox. Some surgical procedures like labia minora reduction or some clitoral reduction procedures, colporrhaphy, perineuraphy, vaginal tightening. These are some procedures which are currently available for genital rejuvenation. A surgical vaginal rejuvenation can be done with the wedge resection or vaginal tightening may be there, or repair of prolapse can be done. I will not go into the details. How can I talk with my partner about the menopause and sex? One should be able to talk with partner with open communication. Open communication is the key, because if there is open communication with the spouse, that strengthens your relationship. Getting older and chronic health problems like heart disease or diabetes that can affect your sexual health and how you feel about your sex. Then what feels good and what doesn't? Time that you feel more relaxed, which positions are more comfortable, whether you need more time to get aroused than before, concerns you have about the way your appearance may be changing, which are the ways to enjoy the physical connection other than vaginal intercourse, such as oral sex or massage. These issues should be discussed with the partner in an open way. That is definitely going to increase the intimacy and the close relationship between the partners. Also, one can consider the meeting with a therapist or sex counselor as and when needed, or couple therapy if needed. That is going to help you in your sexual life. Do I still need to practice safe sex after menopause? Yes, one still need to use condoms after menopause if you are not in a monogamous relationship, and also you have to test for the sexually transmitted infections if indicated. Condoms are the best way to prevent the STI. Vaginal dryness or irritation is more common after menopause. This can cause small cuts or tears during the sex and making you more likely to get an STI. So, thank you so much for the patient listening. This is humble appeal for my Foxy upcoming elections for Foxy committee chairperson. Thank you so much.
Thank you, Dr. Madan, for a wonderful and lucid and informative talk on a very important topic, because this topic is usually not discussed by patients or even by doctors also. And many times patient comes with some other vague complaints. So I think it's better that we go specifically to this problem, ask the patient, and counseling is required along with the partner, where sometimes the patient alone comes and gives the problems and partner will not understand it. So really important topic you have covered. Thanks a lot and best of luck for your Foxy election.
Thank you so much, sir. Thank you so much. Yes. Prajakta?
The topic,
Yes.
Dr. Madan. Best wishes.
Yes. Thank you. Thank you so much.
Yeah. Thank you, Madan sir, for such an enlightening topic. And thank you, chairpersons, for your valuable inputs. Now we'll move on to our last session, that is recent updates in menopausal hormone therapy. For this, I would like to invite the chairpersons, Dr. Tanushri Deshpande ma'am. She is treasurer of Indian Menopause Society, Pune. And madam is at Director Mother's Care Clinic, Sadashivpet, Pune. And next chairperson is Dr. Somalata ma'am. She is consultant OBGYN at Vijayawada. Madam is at present secretary for the Vijayawada Society. And she has been awarded so many awards in her curriculum. So I would like to ask Dr. Deshpande madam to invite our next speaker, Dr. Prerna Kishan ma'am, for the topic recent updates in MHT.
Good evening. Welcome, Dr. Prerna. Dr. Prerna Keshan. She's a consultant OBGY, infertility specialist, and endoscopic surgeon. She has many national and international publications. She's East Zone leader for YTPC Foxy, Yuva coordinator Foxy, member of Breast Committee. She has won many national awards. So I invite Dr. Prerna to give her talk on a very important topic, that is recent advances in
Thank you, ma'am. Wishing you all a very good evening. And I'm immensely honored to be a part of this wonderful scientific session today. Is my screen visible?
Yes.
Yes, ma'am.
So wishing you all a very good evening, and I'm immensely honored to be a part of this wonderful scientific session today and extend my heartfelt regards to all the office bearers of AMOGS, Dr. Kiran Purtakoti sir, Dr. Vipin Pandit sir, Dr. Anita Saha madam, IMS president, and my very beloved Dr. Ragini Agarwal madam, and the chief guest for today, Dr. Suchitra Pandit madam, and our guest of honors, Dr. Anita Saha and Dr. Anju Soni madam, and my very loving friend, Dr. Madan Kamble, for giving me this opportunity to share this dais with you. Thank you, Dr. Madan. And it will be a great journey going through with this spree of the academics, along with knowing people around across the country. And I request all the chairpersons, our chairperson, to kindly bless me for this wonderful session. With this, I am entrusted with this topic of recent updates in menopausal hormonal therapy, wherein we will be in the coming 5-10 minutes, we'll be going through array of list of all that we can prescribe for our ailing menopausal women, because we have heard wide and spread by Dr. Ragini madam and Dr. Madan also regarding all the sexual issues as well as the GSM and all. And a lot of it have been said on lifestyle modifications. And definitely, this is something which we all as women always feel, and we always need to understand that I complain about getting older, but I don't want anyone to know how old I am. So that is it. Whenever we ask a patient aging, she's 60 years of age, she'll definitely say, I'm 58. She'll never say her right age. So this is what happens in an aging female. They happen to close their age to the public and then manifest as they are a little younger than what the actual age is. So this is where we as IMS experts and we as the care providers need to creep in. Now, these are the stages of menopause as per this Indian Menopausal Society 2008. The World Conference of International Menopausal Society at Madrid had managed to give the stage 1, stage 2A, 2B, and stage 3. That roughly around 3 to 4, 5 years prior to menopause. Then stage 2 is 1 year. That is the confirmation period. 2B is up to 5 years after the menopause, and stage 3 is from 5 years after menopause up to her lifetime. And there are an array of events that is happening upon these particular stages. And the best thing to do in stage 1 is to establish communication. As Dr. Ragini ma'am has said, talk, and talk. Just dig out all her unspoken problems. We need to treat in the stage 2B, but stage 3 is something we need to prevent. We need to prevent all these, like the atrophic changes occurring in the ischemic heart disease, ranging from osteoporosis as well as the cerebrovascular accidents and the Alzheimer's disease. So this is an effective staging of the reproductive aging workshop plus 10, that is known as the straw planning committee plus 10 review, which advances in understanding the critical changes in hypothalamic pituitary ovarian function that occur before and after the final menstrual period. And the straw plus 10 staging system is applicable to women of all ages and demographics, as well as BMIs, and to all lifestyles. So we need to understand the straw plus 10 staging, and this is how we need to actual terminologies. We need to understand that the reproductive transition, the menopausal transition, and the postmenopausal period in detail with the principle and the supportive criteria, which has descriptive characteristics in total. The straw system at the staging of reproductive aging workshop has an array from menopausal transition to the postmenopausal transition, wherein we have terminologies like early and late. Now we need to understand where we actually need to creep in. And this is where this particular topic is all about: when and whom to give the hormone replacement therapy. So there have been consensus from various organizations and various bodies and various authorities like the NICE, the ACOG, RFOGC, then the International Menopausal Society, the US Preventive Task Forces, as well as the RCOG. Now we'll go into detail of what each one has to say. Definitely these symptoms proper are the mainstay of our treatment therapies, that we need to look for hot flushes, we need to look for osteoporosis, we need to look for decreased libido. We had a full talk on sexuality. We need to look for depression, we need to look for mood swings. But what we need to actually understand is that every patient has to have a tailor-made approach. This is the January 2014 ACOG practice bulletin with the management of menopausal symptoms, wherein it was said that systemic hormone therapy with estrogen alone or in combination with progesterone is the most effective therapy for vasomotor symptoms. Now, low dose and ultra low dose systemic doses of estrogen are associated with better adverse effect profile, and they've recommended that healthcare providers individualize care. This is a very, very important thing to understand, that every care should be individualized. We cannot just say that all vasomotor symptoms patients has to undergo a combination therapy. Now, this woman has to be treated with the lowest effective dose and for the shortest duration. And the risk of combined systemic HT include thromboembolic disease and breast cancer, that has always to be kept in mind. As Dr. Ragini has said in her talk, that systemic hormone therapy should be avoided as and when it can be. Now, as per the urogenital atrophy is concerned, Dr. Madan has quite a lot explained about the GMC, and this is about offering long-term vaginal estrogen, and even if after taking HRT, things are not getting relieved. Now, the HRT for libido is that the transdermal estrogen patch, transdermal estrogen gel, transdermal testosterone. Now, this is by the Australian research along with John Studd. Now, the HRT for depression, if we say, it is lack of estrogen and there is no role of antidepressant. As Dr. Ragini has mentioned, that even if there is a depression in this patient, antidepressants need not be prescribed. It is a transdermal estrogen that can help these patients. And the AICOG 2018 duration of systemic therapy has to be tailored approach. The patient can be on lower the doses and can restart if the symptoms occur. As per the NICE, starting and stopping the HRT is supposed to be the choice of the patient when to stop HRT. It does not choose any arbitrary limits. And previously it was held that HRT should be stopped after 2 to 5 years or at the age of 60. But right now, it's nothing like that. Now, the menopause hormone therapy guidelines based on the analysis conducted by the World Health Organization is that the MHT reported not only enhances the quality of life as per the recording of physical examination and other tests, it also improves the symptoms proper with customized tests that can be conducted for each risk factor based on basic examination. Now, these are the basic examination. I'm not going into much detail of all the examinations that are required and investigations, but this is something very recent. The ACOG practice bulletin with menopause management has said that SSRIs or SSNRIs, clonidine and gabapentin, are effective alternatives to hormone therapy. Estrogen therapy effectively alleviates atrophic vaginal symptoms related to menopause, and the local therapy is advised for treatment of women with only vaginal symptoms. Paroxetine is the only non-hormonal therapy that is approved by FDA for the treatment of vasomotor symptoms, and the FDA-approved ospefenifine for treating moderate to severe dyspareunia in postmenopausal women was given by ACOG. The NICE guidelines says that the personalized shared decision, this is a very important line, a personalized and shared decision making based on age, symptoms, and the preferences of the client. The HRT is most effective for vasomotor and genitourinary symptoms, we all know. And CBT can also be, the cognitive behavioral therapy can also be offered as a non-hormonal alternative. And this particular webinar is all about the lifestyle modification, and hence cognitive behavioral therapy is a very, very important part of this particular sense, and not recommended for prevention of cardiovascular disease or dementia, we all know. And the discussion helps to aid communicate risk and the benefits that are associated with the hormone replacement therapy. A very recent recommendation in January 2025 by the UK Cancer Survivors in the Gynecological Cancer Society that has been published in the Management of Menopause in Cancer Survivors, it says that personalized risk-benefit discussion for cancer survivors is very important, not automatically excluded from HRT if cancer was not hormone sensitive. Very, very important line. And the development of menopause app for clinical decision support has to be definitely recommended. Now, the FDA developments in July 2025, we are here in a very recent recommendation that is around July 2025, where the expert panel recommends removing the black box of warning from the HRT. We are now removing this black box. The absolute contraindication has to be removed. Now, the evidence shows that benefits and the reduced heart attack and fracture risk, and the FDA seeking public comments on cancer, cardiovascular, bone, and cognitive effects. So the deadline for these comments was September 24, 2025, and we have already received a few. So this is something which is very recent. Now, what we need to understand is that we need to find out what is better, which one is better, and for whom. So the risk assessment is essential. We have to understand the blessings as well as the curses associated with the hormone replacement therapy. The menopause Foxy focus that has been published has an array of advantages and disadvantages published in it, which we all know that the advantage is on excellent symptomatic management of hot flushes, whereas the disadvantage includes more of so the cardiovascular risk as well as the risk of vaginal bleedings. So what we need to understand is where we are not going to use and where is it not required. So this is two different streamlined things which we need to understand and recommend as care providers. And timing is something which matters the most, because early intervention is the key to preventing maximum menopausal damage and the cardiovascular health after menopause transition, pregnancy disorders, and other gynecological conditions. This consensus was given by the European cardiologist and gynecologist as well as the endocrinologist in the European Heart Journal 2021, January 25. That is, the treatment below 60 years of age or within 10 years of onset of menopause showed a significant reduction, almost more than 30% of myocardial infarction or cardiac deaths could have been prevented. And initiating menopause hormone therapy within 10 years of the onset of menopause significantly reduces the myocardial infarction and death around 50%. So the huge percentage of prevention and discontinuation of MHT in such cases may transiently increase coronary deaths. Now, these is as per the NICE guidelines in 2024. Again, the provision of information is that the emphasis should be made on importance of explaining to the woman explaining to the woman about the stages of menopause and the consequences of it. Now you have to offer HRT as first line, but definitely to all those who have VMS and low mood, but not to as a universal catering as a blanket therapy. These are something we all know about the route of administration, the doses of administration. I'm not going to details of it, the transdermal, the subdermal implants and gels and all of the injections. Now we have to identify which particular female is suffering and whom are we going to prescribe what. This is something which is reviewed and transferred and referred to secondary care, as well as when to commence HRT and what are the persistent side effects, how to identify them, and there's the algorithm that we need to follow as per the British Menopause Society. And the review and referral journals of the British Menopause Society says that review should be arranged on MHT with healthcare professional in the first visit 3 months after commencing HRT, and once they settle down on it, annually thereafter. So seeing this particular scene, we all will need to age. The way this particular female is aging, in 2025, she even looks like a diva right away. So we need to understand that we have to work on ourselves today so as to grow old into a person we want to become tomorrow. We need to have a shared decision making with our care provider. That individualization is the key concept. HRT is very, very efficient for definitely for VMS symptoms and the genitourinary symptoms, but tailor-made approach has to be done, not a blanket therapy for all. And for survivors also, for cancer survivors, we need to be very cautious. So when I get old, I don't want people to think, what a sweet little old lady she is. I want them saying this, in fact, oh dear, what she is up to now. So that will be my particular projection. And that is how I seek my blessings from each one of you, all the dignitaries present here, for my future endeavor in FOGSI as the YTPC chairperson. Thank you all. Thank you for your pleasant and have a pleasant evening. Thank you. Thank you, ma'am. Thank you, Dr. Madan. Thank you, chairpersons.
Thank you, Dr. Prerna.
I think I could have made a point.
Yes, requesting chairpersons to comment.
Thank you, Dr. Prerna. It was a very specific, concise presentation addressing all the key factors which are there in the menopause hormone therapy. So thank you so much.
Prerna, please stop share.
Yes.
Yes, I'm Dr. Somlata.
Yeah, welcome, ma'am.
Yeah,
welcome.
I've just joined just when Dr. Prerna has started. It was very good, sir. Dr. Prerna explained everything for as routine. Just counseling of the means like the persons who come along with the patient is also important. Just like during the menopausal symptoms explanation, what we are doing is counseling of the family members is also important regarding the symptoms.
Thank you, ma'am. Thank you.
Yeah. Thank you.
It was fantastic, Dr. Prerna.
Thank you. Thank you, Dr. Madan.
I think Prerna ma'am should tell Young Promotion Committee rather than Young Talent Promotion Committee.
Yes. Anita ma'am,
Thank you, Anita. Yeah, Anita ma'am is there. Okay.
Pragati ma'am, any comments from your end? Please lift.
Yes, Pragati ma'am. Anita ma'am was there. Okay. So, I think all the topics were very well discussed. Now it's time to say a word of thanks now. Shall we end the session now?
Yeah, thank you, Dr. Madan sir, for the opportunity on behalf of Vijayawada Society.
Yeah, thank you, ma'am, for joining. On behalf of AMOGS Sexual Health Committee and Indian Menopause Society, I would like to thank the AMOGS office bearers, Indian Menopause Society office bearers, Anita Shah ma'am, Ragini ma'am, and all the speakers, all the chairpersons who have given their valuable time. Special thanks to Ragini ma'am, Prerna, and all the chairpersons who have joined, all the delegates who have joined for this session for the celebration of World Menopause Day. Thank you again so much, all the dignitaries. Thank you so much.
Thank you. Bye-bye.
Yeah.
Thank you.
Thank you. Good night.
Good night.
Thank you, Prajakta. Thank you, Corona, for the constant support. Thank you, Prajakta.
Welcome, sir.